Coming on to clinical features. So in case of clinical features, what we need to understand is that the steroids are going to affect almost every organ system in the body and in manners that may be very specific to some. So we see first we see at the carbohydrate metabolism. So in case of carbohydrate metabolism, it is going to cause here increased gluconeogenesis. This is going to occur because of two reasons. One is increase in the PEP carboxy kinase substrate for substrate availability, gluconeogenesis. This is going to occur by two means. One is there is increased free fatty acids as well as there is increased alanine. So once the substrates are going to be there, there is going to be more glucose in the system, in the bloodstream. So that is one thing. The other thing is they are going to affect the pancreas directly. So what they are going to do is pancreas are going to cause dysfunction. That is going to interfere with GLUT2 expression. And one of the most important things is the decrease in the peripheral utilization of glucose. So this is going to occur by three mechanisms. One is there is going to be impaired GLUT4 expression. So this is expressed on the skeletal muscles, and so the peripheral uptake of glucose is going to reduce. So because of that, there is going to be a lot of glucose in the bloodstream. The other thing is the non-insulin mediated glucose uptake is also going to reduce. And the third thing is that there is going to be reduction in the protein kinase C. So all three things are going to cause increase in the glucose levels. So what are the mechanisms that we discussed? One is there is increase in the hepatic glucose output by increase in the substrate plus increase in PEP carboxy kinase. The other thing is going to be pancreatic dysfunction. And the third thing is this. So first, second and third. This is going to cause impaired glucose tolerance in around 37% of the cases, while frank diabetes will occur in 10 to 15% of the cases. So these are the effects of steroids on blood glucose levels. So on the fat metabolism, in case of fat metabolism, there is going to be redistribution of fat. So the classical lemon on stick appearance is going to occur. So there is going to be centripetal obesity. There is going to be very thin limbs. So why this occurs? So why there is centripetal obesity? So we need to understand two things here. That obesity is of two types. One is central and another is generalized. The generalized one is more common at 55% and central is 45%. So Cushing syndrome will have central obesity. The reason to that is that there is increase in the glucocorticoid receptors. That is in the omental fat area. Then there is another reason. The other reason is that there is increase in the 11 beta HSD1 activity, which converts corticosterone to cortisol. Because of these two reasons, there is centripetal or central obesity. Then there is also going to be redistribution of fat in ways of rounding of the face, which is also known as mooning of the face. What is mooning? So mooning is because there is locally increased activity of 11 beta HSD1. This will cause accumulation of cortisol in local tissues, causing Cushingoid changes. So mooning is when you cannot see the tragus from the front. Patient's tragus is not visible, there is rounding or mooning of the face. Can't see tragus. Okay. So this is the reason for the mooning of the face and central obesity. What is the other problem? Other problem is going to be there is something known as buffalo hump. That is basically a dorso-cervical pad of fat. Plus there is also, so dorso-cervical pad of fat is going to be there. So there is going to be a hump here. The other thing that is going to happen is a supraclavicular fullness. So supraclavicular fullness is going to be there. So we will not be able to see that clavicular fossa is there, that we won't be able to see. We'll finish the lipid as well as the weight gain and the obesity part first. So in case of this, what we are going to see is that why there is weight gain in case of Cushing syndrome. Again, we have to see multiple things. One is there is increase in appetite. So why there is increase in appetite? One is there is a direct effect of cortisol. So there is a direct effect of cortisol on the feeding center. That is there in the arcuate nucleus of the hypothalamus. Secondly, there is going to be increase in the AMP kinase activity. It is the same enzyme at which metformin acts. So, and it inhibits this. So this also explains this enzyme's role in weight gain and weight loss, particularly by metformin. It also has increase in the insulin resistance. Insulin resistance is going to increase. So if this insulin resistance is going to increase, this will also cause an increase in the appetite. The other thing is, there is increase in the neuropeptide Y. This is the orexogenic peptide. This will cause increase in the appetite. Reduction in the CRH levels. So this will cause again increase in the appetite. So first part is this, that we are going to have increase in appetite. There is increase in the adipogenesis also. So adipogenesis is increased because of the following reasons. One is that cortisol, what it does is, the primitive mesenchymal cells can be diverted towards osteoblast, can be diverted towards adipocytes as well. So the mesenchymal cells are diverted towards adipocytes in presence of hypercortisolemia. So it is diverting this mesenchymal cell which is the precursor cell into adipocytes. There is increase in the activity of lipoprotein lipase. So there is increased breakdown of fats into fatty acids. This will further cause the problem of appetite is also going to be there. The problem with this adipogenesis is that this free fatty acid is going to cause a substrate increase for gluconeogenesis. So this will worsen the carbohydrate metabolism as well. It is also causing an increase in the glycerol 3 phosphate dehydrogenase. Now after this, what are the other two factors? So the other two factors are, there is reduction in physical activity. The physical activity is going to be reduced because of two things. One is proximal myopathy. Second is the neuropsychiatric illness. Now another cause of increase in weight is the fluid retention. See, this is the state of increased hypercortisolism. So this cortisol is going to now act in supraphysiological amounts at the mineralocorticoid receptor as well. And once it acts here, it will cause water retention and sodium retention. This will further cause increase in the weight. These factors are going to cause an increase in weight. So what are they? One is your increase in appetite. There is increase in the adipogenesis. Third is fluid retention. Fourth is going to be your decrease in physical activity. Where we will see weight loss in Cushing's syndrome. If there is uncontrolled diabetes, so we know that uncontrolled diabetes is going to have a catabolic effect. We can have some infections or sepsis. This is also, both are catabolic states. We saw that in ectopic ACTH producing Cushing syndrome, the tumors are going to be so fast, the onset is going to be so rapid that weight gain will not occur. Same thing will happen with adrenocortical carcinoma. If there is a very rare scenario where there is a TSH plus ACTH co-secreting adenoma, or in cases of McCune-Albright. The most common cause of Cushing syndrome in the infancy period. Now we come to the protein part. So, in case of proteins, what are the factors that are causing catabolic effects and how they are manifesting? Proximal myopathy. So proximal myopathy, clinically, how we are going to say that the patient is having difficulty in getting up from squatting position, getting up from a deep chair, or he is having or she is having difficulty when they are walking on a staircase. These are the factors where they are going to have, we can assess clinical pointers towards proximal myopathy. Now, what is the reason for this? So, the reasons are, one is there is a direct effect of cortisol on 2-3 things. One is it inhibits the local IGF-1, insulin-like growth factor 1, as well as the AKT signaling pathway. There is reduction in the protein synthesis. This will cause increase myocyte apoptosis as well, increased catabolic effects. And what it is going to do at an ultrastructural level is type 2 muscle atrophy, while type 1 relative hypertrophy. So type 2 is the red muscle, the oxidative muscle with myoglobin, and it is important for fast contraction. So this is going to get atrophied. What are the other things that may contribute to this proximal muscle weakness? They may be hypokalemia. We saw this, it is 10 to 15% cases in case of Cushing's disease, while in case of ectopic Cushing's, it is present in 90 to 95% of the cases. There may be concomitant hypomagnesemia, hypophosphatemia, there may be concomitant vitamin D deficiency, or there may be hypogonadism. Alright, so these things will cause proximal myopathy. So what else can occur? What else can occur is there can be striae. Striae are present in 60 to 80% of the cases. Proximal myopathy is also seen in around 60 to 70% of the cases. Striae are a common discriminant feature. We'll get to what a discriminant feature is. So they should be more than 1 centimeter. They should be wide with tapering ends, violaceous in color or purplish, and deep, and they are present either at the stomach, they can be present in the armpits or axilla, they can be present in the inner thighs, they can be present anywhere in the body, but these are the areas. Striae occurs because of primarily 2 things. One is your venular dilatation. The second thing is thinned out dermis. There is loss of perivascular collagen support. Number 1. Number 2, dermal collagenous atrophy. Why this occurs? This occurs because protein synthesis is less. Consequently, the collagen synthesis is reduced and defective. Why this is happening? The cross-linking is defective. Because of this, what is going to happen is dermal atrophy and stria are going to develop. Is there any cause of stria not occurring in patients with Cushing syndrome? They do not occur in childhood Cushing's. They do not occur in adrenocortical carcinoma, your ectopic ACTH producing Cushing syndrome, hypercortisolism with androgen excess. So they don't occur. And where do you see stria in non-Cushingoid cases? So here we see it is very common. Obesity. It can be seen in puberty, pregnancy, any pseudo Cushing state. So here we can see stria in a non-Cushingoid status. We also have something known as bruisability. That on any trivial trauma we see there is some discoloration is there, some bruise is there. There is also plethora. Plethora is there is redness or there is some violaceous color on the face. There is a reddish hue on the face. This is also because of loss of dermal collagen. Cuticular atrophy. This is also very important. So why cuticular atrophy occurs? Cuticular atrophy, it is very interesting. Hypercortisolemia has an inhibitory effect on the stratum corneum. Multiplication. This will cause dermal atrophy mainly of the stratum corneum. So here we come to a point where this gives us some kind of clinical clue that the patient is now going towards eucortisolism once either we remove the tumor from surgery or due to any other cause. So once we treat this hypercortisolism, this inhibition of stratum corneum goes away. We have treated Cushing's disease or Cushing syndrome and this cortisol is now normal. So this multiplication inhibition goes and the patient goes into something which is known as desquamation. That is increase in the multiplication rate of stratum corneum that causes increase in the stratum corneum turnover, causing desquamation. So this is a clinical clue that the patient is going from hypercortisolism to eucortisolism. We also have something known as coagulation defect. It's a procoagulant state. This procoagulant state is because of reduction in fibrinolysis, because of inhibition of the fibrinolytic pathway, and there is increase in factor 8, factor 13 and increase in fibrinogen. In case of coagulation defect, there is reduction in the fibrinolysis or the fibrinolytic pathway, where there is reduction in the plasminogen activator inhibitor. So this gets inhibited. So there is reduction in the fibrinolysis, while there is increase in the factor 8, factor 13 and fibrinogen. So this causes ultimately a platelet clumping or rather a procoagulant effect. So why this is important is that in all cases, whenever we are operating a Cushing's disease case, or we actually always, whenever we are treating or clinically examining, we always look for some sort of thromboembolic episode, whether it is a deep vein thrombosis, whether it is pulmonary thromboembolism. So we always need to be very wary of this kind of a coagulation procoagulant milieu in this patient. That is very important, and we should not shy away from giving patients who are already at risk of immobilization, or there is some other defect is also there. So we should always give the anticoagulation, or we can also give any kind of pneumatic compression, or we can give the prevention in case of elastic stockings or pneumatic compression. So these things are very important. Now coming on to the bone. So there is osteoporosis and osteopenia. So why there is osteoporosis or osteopenia? There is reduction in the osteoblastic activity as well as osteoblastic number. Why? Increase in the apoptosis of these cells, diversion of the mesenchymal stem cells towards adipocytes. We saw this previously as well. Impaired collagen synthesis. Also reduction in, we saw this before, local IGF-1 levels at the epiphysis. One is that. The other is there is increase in the osteoclast. Why? There is either enhanced production, there is increase in the rank ligand, or there is reduction in the osteoprotegrin. So rank ligand will always cause increase in the resorption, while the osteoprotegrin will inhibit this. This balance is gone and it goes more towards the resorption. The third thing is that there are glucocorticoid induced alterations. Hypocalcemia because of reduced absorption. There can be hypercalciuria. Then there can also be secondary hyperpara, and it can be also because of hypogonadism. Now, the most important part clinically is, once we cure or we put the patient in remission, the patient will slowly improve his BMD levels. Why? And this will never occur in case of a postmenopausal osteoporosis versus your glucocorticoid induced osteoporosis. So why this will happen? Because the microarchitecture is not altered. So once this hypercortisolemia is eliminated, what we can see is slowly the effects of glucocorticoids on the bone will abate, and once they will abate, slowly with calcium and vitamin D supplementation, and in case of vertebral fractures or reduction in case of height due to vertebral fractures, or there is some other problem in the patient, there is a history of pathological fractures, there is some history of spinal epidural lipomatosis. If in those cases, what we can give is a anabolic agent, which is teriparatide. Alright. In postmenopausal osteoporosis, on the other hand, the patient's microarchitecture is also altered. So, the increase in BMD is not going to occur solely on the calcium vitamin D. And since the microarchitecture is problematic, just an increase in the BMD via DEXA will not suffice. For this, we have to go for what is known as trabecular bone score, which looks at the microarchitecture which primarily affects the trabecular part of the bone, which is the metabolically active part of the bone. So we as endocrinologists, we should actually go for understanding the trabecular part of the bone more, because that deals more with the metabolic component of the bone, and that is why this is also known as osteocrinology. After protein metabolism, what else can be there? So there is a thinning of skin, which we saw, which is also known as parchment paper like skin or cigarette paper skin or cigarette paper thinning. So this is known as Liddell's sign. Liddell is a very important scientist. He has done the Liddell sign, Liddell protocol, Liddell syndrome. It is also, one is known as the collar sign. It is the same thing. So after this, what we see is what are the causes of hirsutism. Why hirsutism should occur? So hirsutism occurs because of increase in the androgen levels. That can be because of increase ACTH is going to cause activation of the adrenal cortex, and this will cause further zona reticularis activation, and hirsutism will occur, androgen excess will occur. And one of the features is this hirsutism occurs in 60 to 80% of the cases. 60 to 80 is occurring everywhere. Striae is 60 to 80%, protein catabolism is 16 to 80%. So this is going to be seen more in the ACTH dependent causes, obviously. Concurrent cortisol and androgen secreting tumor can also occur. ACTH itself can cause this. Then hyperinsulinemia or insulin resistance is also a very important feature. Like we saw in PCOS, insulin resistance will reduce the SHBG, and once this is reduced, the free form of the hormone rises, so the effects rise. So that is how hirsutism will occur. What is hirsutism? Hirsutism is growth of black thick hair in a female in androgen dependent areas. So what are the androgen dependent areas? We can see that in the modified Farman-Galloway. We have to see the upper lip, we have to see the chin, the chest, the back, thighs, all these things we have to see. What we don't have to see is the sideburns. But here in hirsutism, there is another problem. One is that there is insulin resistance. The other problem is hyperprolactinemia. So if hyperprolactinemia occurs, this can occur because of there can be a mass effect. The mass effect is going to cause the stalk compression. That stalk compression, the inhibition of this lactotrophs by this dopamine is going to reduce, and prolactin is going to go up, and it goes up in 20 to 30% of the cases. And in those cases, this can be another problem or a contributing factor towards this hair growth. The hair growth can also have a cause where cortisol in high amounts can have a positive impact on the pilosebaceous units. And this pilosebaceous unit activity will cause increase in this hair. But the true hirsutism occurs very few times. It occurs only around 10% of the cases. Most of the time it is a vellus hair, thin hair or lanugo hair. Is there any feature in which the patient can have no features of protein catabolism? That is, protein catabolism is not there, but Cushing syndrome is there. So they can occur in mild Cushing syndrome or cyclic Cushing syndrome, childhood Cushing syndrome. When there is hypercortisolemia plus androgen excess. In case of adrenocortical carcinoma or ectopic Cushing's syndrome. Menstrual abnormality. So what is the most common menstrual abnormality? Oligomenorrhea. Oligomenorrhea is the most common menstrual abnormality. It occurs, menstrual abnormality as a whole can occur in 70 to 80% of the cases. So the reasons are cortisol mediated inhibition of the gonadotropin axis. What is going to occur here is that cortisol is going to negatively affect the GnRH pulse generator. If that is going to happen, GnRH is going to reduce, the gonadotropins are going to reduce as well. That is, FSH-LH will also go down. Then your estrogen, progesterone, everything goes awry, and there occurs menstrual abnormalities such as oligomenorrhea. Later it can get converted to secondary amenorrhea. Other factors that will affect this kind of presentation. The other thing is, apart from the GnRH axis suppression, one is your GnRH suppression, second is hyperandrogenemia. So the same causes of hirsutism, insulin resistance, hyperinsulinemia. Secondary PCOS can occur. Prolactin, hyperprolactinemia can occur. These are the causes of menstrual abnormalities. What other problems are going to happen? One is your hypertension. So what in hypertension is going to happen? 25% of the exogenous cases will have hypertension, while 75% of endogenous will have hypertension. What are the causes? So this is very important because this will give us a clue towards which group of drug to use. Increased vasoreactivity, to vasopressors such as angiotensin 2, endothelin 1 or catecholamines. Alright, number 1. Then fluid retention, because of cortisol action on mineralocorticoid receptor. There is fluid retention going to occur because of insulin resistance also. The third thing is that there is augmented renin substrate production by the liver. This is one of the few anabolic actions that cortisol has on the liver. Reduced nitric oxide synthase activity. So what nitric oxide synthase does? Increase the production of nitric oxide, and this causes vasodilatation. This will not occur, so BP will increase further. Increase in the catabolism of vasodilatory prostaglandins, and there is increase in the DOCA, deoxycortisol, because of ACTH increase, and this will further cause, we all know, in case of CAH in alpha 11 beta hydroxylase deficiency, this is what gets accumulated. This will cause further increase in the hypertension. This all will cause increase in the BP. This will cause, so you can see that what we have to do, we have to block this mineralocorticoid action, this glucocorticoid action. So what should be the drug of choice? Spironolactone. Spironolactone is the drug of choice. So this spironolactone should be titrated slowly. Initially started at 25 BD, can go up to 200 mg. What else can happen is, there can be headache. Why there is headache? Because of adenoma per se. So because of adenoma, because of increase in the intrapituitary pressure, intracellular pressure to be more specific, there is going to be increase in headache. There is going to be increase in headache because of sinusitis, because of cortical venous thrombosis, and there can be glaucoma, benign intracranial hypertension, which is now known as IIH, idiopathic intracranial hypertension. What will happen in the brain? Another thing, another clinical clue to the etiology. So we have seen that in case of exogenous Cushing's, the patient has a lot of euphoria. That also actually contributes to the abuse liability. While in case of endogenous, we see that there is a lot of depression and even psychosis. Ocular manifestations are also there. So ocular manifestations, there can be cataract, that is posterior subcapsular cataract, usually bilateral. There can be glaucoma. These are the most common ones. The other is proptosis because of increased adipogenesis, and this fat is going to get accumulated in the retroorbital area, that will push the eyeball out. There can be central serous retinopathy, chemosis, redness in the eyes, hypertension along with metabolic alkalosis, as well as hypokalemia is seen more commonly 90 to 95% of the cases in ectopic Cushing syndrome. That is what we are seeing. So that is also going to occur.